Hello, my name is Blake Denison, and I'm the Director of Clinical Perfusion at the University of Texas Dell Medical School. I must be a very lucky guy because this is the second year in a row that I've been invited to speak at this conference, and I'm honored today to talk to you about ABOi and compatible heart transplantation and total blood volume exchanges. I think it's customary to start these things off with a quote of some sort, right? And I think this one perfectly describes my feelings the first time I ever did an ABOi incompatible heart transplant. I think we've all felt this way at some point as perfusionists, but for you students out there, take these challenging problems and dig deep into the science to expand your understanding of this amazing field that we're in. I also think it's customary to recognize the scientific pioneers that make our jobs possible. This is Dr. Karl Landsteiner, and in 1901, he classified the distinctive blood groupings. Blood transfusions had been attempted for centuries with varied and lethal results, but Landsteiner began to mix blood samples from different people and observed their reactions. He noticed that the samples agglutinated and some did not. Upon further study, he found that the reactions existed through a protein-based interaction between the donor and the recipient. He was able to classify these differences as the antigen-antibody blood grouping system that we use every day in our practices. His discovery quite literally saved millions of lives and won him a Nobel Prize in 1930, which I think is worthy of the fancy Google Doodle that pops up every year on his birthday. This is my son Carter, and he is almost 18 months old now. His first year of life was pretty much bug-free, but when we put him in the cesspool known as daycare, he began to have all kinds of illnesses. Tummy problems, he got pink eye, we got pink eye, water faucet runny nose, a terrible recurrent cough. He got pink eye again, and that's despite eating all his fruits and veggies. He ended up needing surgery to alleviate some of these nasty infections. I show you that because Carter is not unique. Every one of our immune systems is immature at birth, and it's fortified as we come into contact with new pathogens over time. For your typical bacteria, the B and T lymphocytes are the workhorses, and they let their friends know that a new invader is present. This chemical message is proliferated to plasma cells, which are immunoglobulin and antibody factories, which release these messengers all over the body to bind to this bacteria, neutralize it, and mark it for destruction when it is encountered again. I have a coworker that likes to say Shazam when he changes the subject mid-conversation, so Shazam. In the United States, we have a small but steady increase in heart transplants each year. Texas is second only to California in heart transplantation, which means that Texas perfusionists are second only to California perfusionists in sleepless nights. When you break the numbers down by age, you can really get a sense of how limited a therapy transplantation really is for our smallest patients. There simply aren't that many organs available for these infants. In fact, the amount of kids waiting continues to increase each year. The age distribution of these kids for heart transplants has been relatively flat, though, over the years. But luckily for our smallest babies, we have been able to introduce new clinical therapies which have been able to reduce the mortality for these patients while they wait for the extremely rare organ to become available. In the past, ECMO would have been a last-ditch resort for these children, but now we can use long-term mechanical support like the Berlin heart. I know that the theme of this conference is to honor the amazing women that we get to work with every day, and I can attest that a great majority of my clinical training has been shaped by the rock star women I've been fortunate to work with. I couldn't help but want to spin this frame a little bit differently to honor one of the strongest and most resilient girls that I've ever met. This is Zaria Jackson, and at 3.5 months old, her mom noticed that her feeding had dropped off significantly. And she was lethargic. Not only that, but her breathing was increased and irregular. She didn't really have a fever or any symptoms of illness, but her mama knows best. Her first visit with the cardiologist showed that she had a severe cardiomegaly and diffuse pulmonary venous congestion in the presence of severe dilation and depressed contractility of her left ventricle. It is a bad set of cards to be dealt as a newborn, but luckily, as the other slide showed, we are not without options to bridge her to transplant. Very soon after her presentation to us, we took her to the operating room and we implanted a 10cc Berlin heart pump. Now, if you don't know, our program is in its infancy too. At just 3 years old, we have amassed an expert staff from some of the top centers in the country. Clinicians who have been pulled together with a common goal to rethink congenital heart surgery and how a team is supposed to function around and for our patients. For little Zarya here, she may have been our first Berlin heart at Dell Children's Hospital, but the team was able to successfully implant and manage her care because of our extensive history with the device elsewhere. Success does not come simply because of familiarity, though. Outside the OR, our nursing staff, respiratory therapists, and physical therapists had very limited experience with this type of device. This is why I must sing the praises of my colleague Richard Owens, who many of you may know. The amount of clinical training that he implemented rapidly to make sure the staff was familiar and comfortable with the device was quite remarkable. So way to go, Richard. Over time, little Zarya began to do many of the things that any 4-month-old would do. Despite being attached to a pneumatic blood pump, she was able to gain enough strength to sit up and play. And I must say that she spent an enormous amount of her time and energy trying to draw a smile out of anybody that passed by her room. But for us, this therapy was always just a bridge. And given the limited amount of organs that become available, we cannot simply wait for a perfect match, which may never come. Her immature immune system gave us a unique opportunity to cast a wider net for the limited amount of organs which become available each year. We were able to broaden our search beyond ABOi compatibility and go after almost any heart that matches based solely on its size. And with one phone call, we had accepted a heart of a different blood type. And I like to think what Dr. Carl Landsteiner would think. I can only assume he would be astounded to see that in just 100 years' time, his discovery could be manipulated in the presence of modern medicine. Through research conducted in the early 50s, there was growing evidence that an immature immune system of the neonate and infant may provide a unique window of opportunity for better acceptance of transplanted organs, more so than any other time later in life. Anti-A and anti-B antibodies are simply not present at birth because newborns cannot synthesize immunoglobulins due to their undeveloped immune system. The theory on ABOi incompatible heart transplants is that an exchange transfusion of the recipient should be done at the initiation of cardiopulmonary bypass. This removes the entire blood volume of the patient and reduces the concentration of circulating antibodies and replaces them with plasma that matches the new donor organ. When the body begins to create new lymphocytes, immunosuppressant therapies of mycophenolate and tacrolimus are there to limit the body's response to the new organ. Successive dilutional isohemagglutinin titers must also be taken in the post-operative period. The T cells have a major role in your immune response as they are activated when they encounter the major histocompatibility complex of non-self antigens. Tacrolimus and cyclosporin do the same thing by inhibiting the early activation of these T cells. Mycophenolate disrupts the proliferation of the T cells and can even cause apoptosis of any activated T cells. Both of these in combination with each other have been shown to significantly reduce the body's defense mechanisms against a foreign organ. Now, suppressing your immune system can have very serious side effects because, after all, you have just completely obliterated your body's ability to fight infections. But over time, these therapies are getting better. Many centers now prefer tacrolimus over cyclosporin because it has been shown to be less nephrotoxic. In 2001, Toronto sick kids published their experience on the first 10 patients to undergo ABOi incompatible cardiac transplantation. These children showed no or very low titers of isohemagglutinins. No hyperacute rejection occurred, and then although 2 patients died, it was determined they were unrelated to the ABOi incompatibility. By 2006, the United Network for Organ Sharing, UNOS, had issued guidance for a policy change which allowed for listing of infants to receive ABOi incompatible transplants with a maximum age limit of 2 years old and antibody titers less than or equal to 1 to 16. Another part of the criteria was that the ABOi incompatible heart will only be offered once all ABOi compatible possibilities were exhausted. So as you can see in the last few years, this therapy has become quite utilized. And it's easy to see why, because when compared to the standard method, ABOi incompatible heart transplants have equivalent outcomes of survival. They also have equivalent rates of rejection. And in some instances, they are actually superior to the ABOi compatible cohort with less infections overall. One of the unique aspects of our program is that the perfusionists travel as members of the procurement team to deliver cardioplegia to the donor organ. You can see Richard Owens and Kellen Roston here waiting to leave. Some may think that it's unnecessary to do something like this, but in my mind, there's no member of the clinical team who is more versed in stopping tiny hearts like this, since we do it every single day. After all, we're talking about an extremely delicate organ, roughly the size of a strawberry. Procurement and transplants in general are huge logistical nightmares, which takes significant coordination from teams all over the United States, which ultimately it boils down to a race against time. Being centrally located in Texas is actually beneficial given the population centers that radiate out from us. 250 nautical miles will get you to Houston or Dallas in about an hour. 500 nautical miles will get you back from Memphis in about 2 hours, and 1,000 nautical miles would get you from Chicago in about 3 hours. But for a patient like Zaria, with limited amount of hearts available, we cast our organ search criteria at 3,000 nautical miles, which covers the entire United States. Shazam! Back in the OR, we have our own set of challenges. Our job is to make sure that we can safely remove the patient's native blood, which would trigger a vicious acute rejection, and replace it with a physiologic blood recipe that provides a conducive environment for the new inbound organ. So how do we do it? Well, it starts with some math. For little Zaria at 8.5 kilos, we calculate her total blood volume with 85 cc's per kilo, which gives us a total blood volume of roughly 725 milliliters, which is just a bit smaller than a liter bottle of water. Our protocol for ABOi incompatible heart transplant requires a 1.5 total blood volume exchange. So this gives us approximately 1,100 milliliters of volume that we have to replace. Now I know you're thinking this might be a typo here, but 1,100 and 1,300 don't match. Well, when we start the exchange, our venous and arterial lines are primed with blood. The first 150 milliliters or so of some of the volume being discarded is just good prime blood, so we have to simply round up to account for this. Given the normal prime volume of 650 milliliters and the new prime volume for the exchange, our entire circuit must be primed with nearly 2 liters of blood. So how do you create a blood volume so large and still make it physiologic? Because if you've ever measured the electrolytes on bank blood, you know that it's downright nasty. Even blood washed with saline can cause inordinately high sodium levels when buffered with sodium bicarb. For us, we prime the entire circuit with 2 liters of plasmolite and 1,500 milliliters of half normal saline. Then we add our O-positive blood, which matches Zaria's blood type, and add AB-positive plasma, which matches the donor organ. Now, half normal saline has a sodium of 77 millimoles per liter, but by adding it to the plasmolite and extremely acidotic blood products, we can normalize the pH and maintain a physiologic sodium when sodium bicarbonate is added. One key piece to every circuit is obviously heparin, and we add 7,000 units to this mixture. That may sound like a lot, but for us, this circuit size requires 3,500 units. It could be easy to forget this, but you also have to account for the heparin loading dose, which will be removed from the patient during the exchange transfusion. So we add their loading dose into the circuit also. You can see that the total additives of the circuit are well over 5 liters, and we condense it down with a hemoconcentrator to just shy of 2 liters. After all that was done, we measured the colloid osmotic pressure of our circuit and determined it was around 11, which anything below 12 can result in third spacing. So we add 50 milliliters of 25% albumin to give us a COP of over 16. Once we finished with the prime, we took a blood gas on the circuit and compared it to the patient. Can you tell which one is the patient and which one is the circuit? You can see that even a prime this large, we can really dial in the recipe to match the physiology of the patient. The right side is the prime, and notice how close the sodium and the pH are. That's the half normal at work. The prime is one thing, but logistically, how do you do it? Well, you set up 2 reservoirs and wire them together in parallel to each other. It's very easy to kill someone in an instant while performing an exchange transfusion like this, so I like to make things as simple as possible by drawing corresponding gradations marked in % complete on the 2 different reservoirs. That way I can quickly tell if something is not going right. You also want to make sure that the top of your effluent reservoir is very well vented. And the cool thing about an ABO incompatible heart transplant is that you could potentially cell salvage the blood given the fact that the patient's own red cells will not be problematic for the donor heart. So when you have everything ready to go, you simply remove the clamp on the effluent reservoir and just begin pumping. You're doing all the normal things that a perfusionist assesses while going on bypass, like pressures, flows, nears, good venous drainage, but you're also exsanguinating a patient and replacing their blood volume with this new recipe that you have created. Once complete, you swap the clamps and engage bypass as normal. The best way to get through it safely is to keep your head on a swivel, have a spare set of eyes watching you, and communicate effectively with the surgeon and an anesthesiologist. This process is not unique to ABO incompatible heart transplants either. It is nearly identical for sickle cell anemia patients who require total blood volume exchange. So last time Richard did one of these, we were able to film the exchange and put the videos side by side to show the entire process.
You all ready?
Ready to go.
Pump on.
Okay, pump on, starting exchange. Okay, that's about quarter percent. Okay, coming up on flow, that's 100% flow there. That's 50% exchange. Okay, working on the pressure, getting good flows. Coming up on flow, that's 120%. Let's pass the 75%. Okay, that is 100% exchange, going on full. Done. Alrighty, let me fix a few things.
If you do this right, this is how it should look when you have completed the exchange. It is a ton of work to put a prime like this together, but you'll need a little bit of diligence and a lot of courage to pull it off correctly. It may be one of the more stressful things a perfusionist can do, but very soon you'll get to see the fruits of your labor. Because you were just one small piece of an entire complicated process of correctly implanting an ABO incompatible heart. Here's Dr. Fraser arriving with the new organ, which you have to remember was carefully removed from a completely agonizing situation. But the silver lining is that this new heart is going to give life to someone who wasn't supposed to make it. By this point, nearly 50 clinicians have had their hand in helping Zaria survive to transplantation. You can see our chief anesthesiologist, Dr. Aaron Gottlieb, walk out to meet the new organ on the helipad, which may seem like a small gesture, but I think it speaks volumes of how invested we really become in our patients. In a few short minutes, we will know if this organ, which traveled hundreds of miles, will serve its new purpose: to replace a heart that was diseased and non-functional. We have been careful about every detail up to this point. We spent 2 full years building the transplant program to put the right clinicians in the right place. And once we got the green light from UNOS, they were all allowed to do what they do best. Since my time as an Eagle Scout way back in the day, a quote by the founder of the Scouts, Robert Baden-Powell, has always stuck with me. He said, "Try to leave this world a little bit better than you found it." I can think of no better way to reach for such a high standard than to apply it to the complex nature of these congenital heart surgeries. We take something broken, a seemingly insurmountable obstacle, and do the hard work that it takes to fix it. Delicately, our surgical team implanted this new heart in its permanent home, which will give a new promise to a little girl who has been sick her entire life. With a cross clamp of just over 3 hours, her heart restarted perfectly, and she was successfully weaned from bypass. Within days, she was up and moving better than ever before. Which isn't that surprising given the fact that she has a brand new heart that works, and she's no longer tethered to a giant Berlin heart driver. Little Zaria spent just over 2 months with us at Dell Children's Hospital. And it's strange to say, but one of the hardest things about her entire care path was saying goodbye as she left us to join her family at home.
74 days, that's how long 6-month-old Zaria Jackson stayed at Dell Children's Medical Center after undergoing a heart transplant. Now she's going home. She was admitted in January after she started showing signs of heart failure. Doctors say they still don't know what caused it. They do know her best chance of survival was a heart transplant. Her surgery was last month. Zaria's mother tells us all the nurses and doctors who cared for her have been like second parents.
I don't know what we would have done without you guys. You guys are amazing, and I appreciate everything y'all have done for her and for my family.
I'm glad she's doing well. This was only the 4th heart transplant performed at Dell Children's.
Before she left, she got many parting gifts, but none more important than this piece of jewelry right here. The inscription inside gives any medical personnel who may come into contact with her a black and white set of instructions to prevent a medical error given her unique condition. And it will always serve as a reminder of her incredible journey. Thank you for allowing me to share her story today.